She needs no further introduction. She gave a lot of teasers this morning about talking about nourishing healthy starts and all the fun that went with that. So, Trina, thank you again for joining us.
Yeah, welcome back, everyone. So I'm really excited to share some information about our journey when I was at Operation Food Search into the food as medicine realm. I'm also really excited about this Canva print that I found. I'm learning how to use Canva for presentation. So you can teach old dogs new tricks. If you could advance the slide. I just put together a little agenda to give you an idea of the trip we're going to go on together today. So I'll tell you a little bit about how Operation Food Search ended up entering food as medicine. Tell you a little bit about the program, what we built over the 5+ years that we were working on it. Get into that participant-centered design that I mentioned before and how important that has been to our process. Talk through maybe a few of the times we had to create and then rethink and then recreate and kind of pivot during our process. Talk about how important data sharing has been in collecting data and making it useful when we talk about trying to change healthcare reimbursement. And I'm going to convince you, if you aren't already convinced, that we are all policy people and need to be engaged in changing public policy. So you are already experts and don't even know it. So I always like to start with a little levity. And I came across this quote when I was looking at food quotes, and it just made me laugh. So life expectancy would grow by leaps and bounds if green vegetables smelled as good as bacon. I thought that was pretty good. Evidently, I looked up Doug Larson. He was a long-term columnist. He was syndicated throughout the US, but resided in Wisconsin. And this is true, right? This is the difficulty when we're talking about changing diets, is that, yes, bacon is amazing. I shared with Mariana last night, I said, I have been vegetarian, but bacon always breaks me. It's the siren song I can't stay away from. But vegetables are great too. And I always try and bring a little levity to this work because we are doing really hard work. The issues that we are addressing are really serious. And I think sometimes we just need to bring a little bit of joy into that work as we do it. I would have liked to known this guy. He just passed away a few years ago. So how it started. I joined Operation Food Search in 2017 as their to build public policy. It was they just finished a capital campaign and they wanted to start championing change. I have done program development and design. I have done 10 years of program and system evaluation, and I was also bitten by the policy bug in one of my positions, where I just learned the power of public policy and how well program and policy can integrate to bring about lasting change. So it was my 6th day of work, just to set the stage. I had been working for my boss for 5 days. She's still a mentor to me today. I very much wanted to impress her that this was Monday of week 2. And I woke up that morning and I had an email in my inbox from Matt T. Jones. I don't know a Matt T. Jones. And it was this NPR story, Fresh Food by Prescription. It was Geisinger Health System in Scranton, Pennsylvania, had just created a food as medicine program, a fresh food pharmacy, Pharmacy. And they had done a pilot and were showing magnificent results treating diabetes. And it was one of the first articles I read where it was like, okay, we have to stop thinking about this as non-compliance, that people aren't changing their diets. And it was an aha moment that it wasn't that they were resistant to changing their diet. They didn't have the means to do so. They lived in an area that was a food desert. They lacked access to consistent, reliable transportation, and they lacked the money to buy healthy foods. And so this system had really started looking at patients in a new light. And that was that we need to have a solution to this to address these barriers. And so I went into work and it had come to my work account and I said, Lucinda, this really strange email came through this this morning, but I wanted to talk to you about it. She goes, I sent that. And I was like, who is Matt T. Jones? She said, oh, he's my husband. And I said, okay, well, thank you for emailing me. I will follow up with him shortly. But we started talking about what the role of food banks could be in this food as medicine movement. The work that I had looked at really had healthcare systems engaging in food as medicine. But as we looked at champion change, what does a food bank look like in the future? This seemed like an area for us to explore. Having just been hired as the director of policy, I, of course, wanted to try this, and I can justify anything if you give me a few minutes. And I was like, well, we can look at this from a policy change perspective. If we start implementing these programs as research demonstration projects, we can use it to help sway state and federal policy. And that is where FreshRx was born. Some days I'm not sure if that was a good idea or not, depending on how tired I am. But overall, it has been such a great experience. I guarantee I'll trip over that at some point. So I just want to tell you guys a little bit about, so we went into our executive director, and Lucinda had been working with her for years already. And she said, okay, she'll go for this if we can show her that there's money to back it up. And so I wrote to my friends at Anthem Foundation and said, hey, have you been funding any food as medicine programs? And they were like, no, what are you thinking of? And so I described the program, and they were like, oh, that falls under essentially looking at healthy moms and healthy babies. And so we were able to get a $50,000 grant from Anthem Foundation to get started. And we were off and running. So we created a program, as I just said. It was for women who were pregnant and were screening positive for food insecurity. And so this is a little bit different than what you guys are doing, though there's some dietary differences. Of course, when you're looking at providing complete nutrition for a pregnant woman who's experiencing very low food security than what you might be looking at if you're trying to work with someone who has an elevated A1C score. From a policy perspective, we decided to focus on Medicaid, because we knew the key to food as medicine is through healthcare reimbursement. And we knew that the state of Missouri pays for more than half of the births in the state. And we knew from the maternal child health research that you're essentially getting a 2-for-1, that by improving the nutrition of a mother, you're both helping her health outcomes. She's less likely to develop gestational diabetes, hypertension during pregnancy, an entire slew of health issues. And you're also more likely to have a healthy, full-term, normal weight baby. And so that is where this idea was born, is that we need to align a program with the state Medicaid program and then start working towards giving them the evidence they need to make this part of the MCO contract in the state. So because it's a nutritional intervention, we had an entire team come together of research and evaluation experts who helped us determine these criteria. And I will say, the criteria are so important. As Mariana was talking about, and Christina was earlier, you have to be sure of who your population is so that when you have the outcomes, you know who they apply to. You know either who it worked for or who it didn't. When you start to stray from your criteria, you start to lose the ability to make definitive statements about who these programs do and do not work for. This was probably the hardest one for us to stick with, the 20 weeks gestation, because we were working with clinics in the St. Louis region, and we would get calls, and it would be, I have a mom, she's 32 weeks, but she's really food insecure. Can you please get her in? And I had a wonderful team of dietitians and chefs and licensed clinical social workers and community health workers who wanted nothing more than to help every family. However, we couldn't muddy the waters. We had a certain amount of time, we had a certain amount of money, and we were trying to prove that this needed to become a permanent part of American healthcare. And so as hard as it was, we would make handoffs to other programs in the community when someone didn't fit these criteria. We used the hunger vital sign screening. So This may be different from your criteria, but everyone had to screen positive for food insecurity. I know some of you are looking at an elevated A1C, and that may not be a make or break criteria for you, but this was, and this already exists in EPIC. So once the American Academy of Pediatrics put out their policy statement that recommended all pediatricians begin screening their patients using the hunger vital sign, EPIC created a little sub-module that can be put into the system with this hunger vital sign screening. An affirmative response to one or both of those questions or statements indicates that there is a level of household food insecurity. And I wanted to make sure I'm stressing household food insecurity. This goes back to my earlier comments about our healthcare system being focused on individual care. Just because this person is food insecure, as someone else said in the last presentation, there is concern. We cannot send food home just for one person. We talked to moms. If we were sending food home and she had children at home and that household was food insecure, it didn't matter that she was pregnant. She was going to feed her children before she would feed herself. And so we made a decision early on in this process that we were going to provide food for the entire household during this project. And that's another place where reimbursement is tricky when we've talked to our payer collaborators. And that is CPT codes and ICD-10 codes exist for individual treatment, not for household treatment. And if someone is paying premiums for an individual to be covered by healthcare, how do we reconcile the current system with the fact that this is a household intervention, right? So that's one of those rubs that exists in the current system, is that we know this is a household metric affecting that individual, but we haven't set up a system that allows us to recognize that through healthcare. And they had to live in St. Louis City and St. Louis County. We started small. Just because we didn't know what we were doing and knew we could start small and grow the program as we were going. Oh, it stopped advancing for me. So let me talk a little bit about the program. As Mariana mentioned, we don't fit easily into any of the pyramid kind of components that in terms of what a food is medicine program looks like. We're kind of between a couple of them. This program was a labor of love for what ended up being, by the time I left the organization after 5 years, it went from me being a single team of 1 with the support of my boss to a team of 15 working to implement this and other food as medicine programs. And there was a lot of pivoting that happened during this program. So we tried to look at whole person health for this. First, we were doing food. We know, though, that food insecurity doesn't exist in a silo. If a household is experiencing food insecurity, there is a very high likelihood that they are struggling with other basic needs: housing, employment, utilities. One of the first things we did was hire licensed clinical social workers. And this is something that is happening now in food banks across the country, but it hasn't been typical practice. But we knew we needed to start breaking down silos if we were going to be successful, because giving food to someone who is currently unhoused is not helpful to them. If you are living on someone's sofa or using a spare bedroom at your sister's house for you and your kids, you're not going to be able to prepare meals that are going home. So the social workers each had a caseload of 40 to 50 families that they were working with at any one time. The first thing we did with each of those families, knowing that food is medicine, this was prescribed for a specific period of time. We had them enroll before 20 weeks gestation, and we aligned it with Medicaid for pregnant women in the state of Missouri, which goes till 60 days postpartum. And so that is when the food would end. We knew from a policy perspective, we started working to expand Medicaid for pregnant women to go out to 1 year postpartum. But that was a long-term plan. In the interim, we knew we needed to focus in on when we could potentially get reimbursement. So we had the social worker who worked throughout the process with each person that was enrolled in the family. We had a registered dietitian who did an entry consult and was available anytime that people wanted to consult with them. We also connected them with our healthcare providers. So if they suddenly had one of our patients, one of our program participants, screen positive for gestational diabetes, that healthcare provider could get into contact with us and say, hey, we need some different counseling right now because this is happening. And then we ended up, after multiple iterations, with a weekly delivery of meal kits, think HelloFresh, Blue Apron, and snack packs. That was probably the longest winding road we've ever been on. So we started with Geisinger. They set up a fresh food pharmacy in their clinic space. So you could essentially go in and go shopping in this gorgeous mini grocery store. We went to the first hospital we were going to pilot this with, and they said, we don't own the space this hospital is in, we rent it out, which I didn't even know that was a thing. So this has all been a learning experience. And I said, oh, okay, so is there space that we could potentially rent out for this? You guys, healthcare space is really expensive. So there was room in the basement. We would need a lot of wayfinding to get people down there. And they said, we can rent it to you for $75,000 a year. And I was like, we are giving away food. Like, we tried to offer them tax credits. We tried many things. And in the end, what we figured out is it wasn't going to work at this particular clinic. So then we called our friends who run the Metro Market, which is essentially a grocery store on wheels. And we're like, what would it take for us to get you to have a stop at the hospital? And they're like, well, it would cost $20,000. We'll be there 2 hours every week. And it's like, okay, so now you're telling me all my participants have to get to the hospital during that specific 2 hours every week. What we landed on next was CCSA shares, so combined community supported agriculture. It was a share of locally grown fruits, vegetables, meats, cheeses, dairy, rice. Missouri, southeast Missouri grows a lot of rice that we partnered with Fair Shares CCSA in St. Louis. And that was great. People loved it. People had no idea. I've shared this with some of you. People had no idea that lived in the urban core that food was growing so close to St. Louis, that they could have an apple that was picked in an orchard 20 minutes from where they lived. And so with my background being in public health, I was really focused on the health outcomes. My path to sustainability for this through policy change was we must show improved health outcomes that result in a decrease in healthcare spending so that I can give a good return on investment to our healthcare partners and convince them this is a good investment for them. One of the things we didn't count on along the way is that people would be interested to know, like, in the fact that their food was local. So we tried to create a loop with our program. We tried to use all local sources of food. And I should say this was funded and we had a lot of money to buy food. So this was a little bit different and the reason we did that is we were a rescue food bank. And as a rescue food bank, we never know what was coming through the doors. Nothing was consistent. And we couldn't build a food as medicine program with that lack of consistency. Food banks across the country are moving towards offering healthy choices. But I remember when I started in 2017, I walked in and there was a truckload of Peeps against the back wall. That it was after Easter and they had donated Peeps. And there was also, a lot of soda that we were getting from someone locally. And I walked in and it was like, okay, we're going to have to order our food because we don't have consistent sources of food. And as much as I love blowing a Peep up in the microwave every once in a while, that is not going to help us have full-term babies here. So we did these CCSA shares. They were about $50 per week per household, just to give you guys an idea of what that looked like. And the reason we went with that is we were trying to fill the SNAP gap. So this was pre-COVID data. Our friend Craig Gunderson at Feeding America calculated out that for the average American household that relies on SNAP, they were short somewhere around $42 per week in meeting that household's needs. And so we wanted to design a program that filled that gap. So the first thing we would do is sign everyone up for SNAP. We would sign everyone up for WIC. And then we would implement this program because we wanted them to have sustainable resources after the Food is Medicine program ended. And so we saw people going from maybe low teens, low 20s participation in SNAP and WIC up into the high 80s in this program. And we knew those were resources they could take with them after the program ended. All right, next slide. So let's talk a little bit about participant-centered design. So I already told you guys that I came up with a plan that we presented to Anthem Foundation of exactly what I thought based on all my conversations with Dr. Andrea Feinberg, who started the Geisinger program, and other people who were innovators in food and medicine at the time, of what our program should look like for a group of 100 pregnant women and their families. We had an intern come in from a school of social work. And I said, hey, we should have some participant feedback as we do this. Like, your job during your internship is to create a participant advisory council and get feedback as we're building this out. She did an excellent job at this. And I didn't realize that I was only like paying lip service to participant-centered design. She came out of one of her monthly meetings. We had 12 women in the pilot who volunteered to be part of this participant advisory council. She was leading it because she had no other contact with the program. They could be as honest as they want with her. It wasn't going to hurt anyone's feelings. We paid these moms because one of the things that I think is really important, I get paid to go to work every day and do this work. And if we're asking them to share their lived expertise with us, we need to honor that as well. So we would provide transportation, we would provide lunch, we would provide childcare, and we would give them a stipend that was equivalent to about $20 an hour for their time with the Participant Advisory Council. They were our partners in doing this work. I took great offense when she came out of the first meeting because they hated my proposal. And I'm sorry, but I'm highly trained, and that bothered me greatly. And I also didn't like this like master's level young whippersnapper like dressing me down. I had worked very hard to get to this point in my life, and I was going to be making the decisions. And I say this because this was transformational for me in my entire career. The way I have approached my work since this very uncomfortable moment is very different than how I approached my work before. And I say that because it was the most humbling experience I've had in a long time. I wanted to throw a temper tantrum, right? I had a 23-year-old telling me what I was doing wrong, and I wanted to be like, no, you don't get to do that. This is my turn to lead something. I'll give you a great example of what was the turning point for me. I wasn't sure if I wanted to end Katie's internship or if I needed to do some self-reflection. We went the self-reflection route, and I couldn't be more happy about that. She came out and she said, okay, we talked about what the recipe cards look like, and the moms have designed what the recipe card should look like based on the fact that they're trying to take care of their kids while they're cooking. They don't want to have to be flipping back and forth. It made no sense. It looked nothing like your typical recipe card. And I said, it wasn't pretty and it didn't make sense to me. I said, no, why would we even do that? And she said, because it's what they want. And I said, no, what I wanted you to do was go in with the two that we made with the graphic designer and figure out if they want A or B. And she was like, she just stopped and like stared at me and she goes, that's not participant centered, Trina. And I was like, how dare you tell me what I don't know. And she was like, if we're really going to be, I admire her. I would not at 23, like if my internship supervisor had like told me something, I would have been like, yes, ma'am. And she was just kind of like, no, that's not truly putting participants at the center of this work. And I ended up hiring her, and that was her job, was to hold our feet to the fire of maintaining that authenticity in what we designed. And it was transformational. This wasn't about me and my ego. This was about what families needed in our community. And once we got to that place and the moms realized that we were listening to everything they said, we had a mom come in and she said, I gave feedback last week and I noticed that you implemented it this week. With the meal kits, you told me which meal kit I should make first because the fresh produce was most perishable, and you gave me a recommended order in which to prepare them this week. And she said, that made me feel so important because I don't remember the last time someone had taken my idea and actually paid attention to it. She was the second person we ever enrolled in the program. Up until the day I quit, she would stop by once in a while, and she called herself an OG for the program. And she'd be like, she was just there to stay. And so it really did make me re-examine why I do this work and how I do this work, and how important it is to give voice to populations that feel marginalized a lot of the time. And to watch women thrive in that environment and become the boss. Eventually, we turned the Participant Advisory Council over to them. It wasn't us going to them for advice. It was, you tell us what you want. And so they would then generate the ideas. And so watching that transformation was really impactful for me too. And so I can't stress enough the importance of authentically engaging your program participants in developing these programs. And they will become your biggest champions. We had to have side conversations with a couple of them. It's like, please stop telling people about the program. We don't have any openings right now, but they were just out in the community. If they saw a pregnant person at the grocery store, they were like, hey, I have something I need to tell you about. And so we were just instead of getting these referrals in from our healthcare partners, we were suddenly just getting women calling saying, I hear you have a program for pregnant women, which also led to us having a no wrong door policy. And that was, maybe this isn't all about, people know what people need. And if you're willing to call me and tell me that you need fresh, healthy food for your family, it seemed counterproductive for me to say, go back to your provider and ask your provider to please do a referral into this program for us. And so we started a no wrong door policy, as long as they met the criteria. Next slide. I don't know why I keep moving back there. One of the things I think that we have spent, when I thought back to what we have spent the most time on around the table as a team, it's transportation. And I think regardless of what environment you are in, whether it's urban, suburban, rural, frontier, this remains one of the greatest issues. How do you get people where they need to be for services? I will tell you, we went through multiple iterations of this. Every year we tried something different. So at first, we had a small group in the pilot, and we decided we were going to, we talked to our regional Uber, and we said, hey, would it be okay if we, at first the thought was, let's Uber moms in to come pick up the food and then Uber them out. And it was like, that takes a lot of time for them. And it was like, how do we get car seats and Ubers? And it was like, wait a minute, what if we just sent the food to them? So we said, hey, Uber, could we, instead of a passenger, could the passenger be a meal kit box? And of course, Uber regionally was like, yeah, sure, that's fine. And so I guess they didn't inform the drivers that this was something that they were going to allow. And so I wish I had had a camera for the face of the first man that pulled up, and our dietitian went out there and literally seat buckled a meal kit into the back seat and put the frozen bag, and was like, okay, someone will meet you at the other end of this journey. And I shared this with a couple of you. It was like our dietitian became a dispatcher, because they wouldn't get out and deliver the food to the door. And so she would have the Uber driver on one phone, and she would have the mom on the other, and it'd be like, he's 2 minutes away from your house. And it'd be like, things would happen like, he says he's in your driveway, you need to come out. What do you mean you're in your driveway right now? What address are you at? And this became a full day every week of our dietitian's life. And I was like, just in case you get tired of being a dietitian, you could easily go into logistics and transportation after this. Ask, and chances are you will receive what you need. I was raised by two tree-hugging hippies. So I was raised to love Mother Nature and the universe, and if you ask in the world, you will get what you need. And that applied so much to this program. We didn't know what we needed until we needed it. I now have contacts in box making. We had some guy who said, hey, I read an article in the newspaper about what you're doing. I run a box company. I'd love to provide the boxes for your meal kits. And it was like, oh my gosh, that's great, because who knew I did not budget for boxes? I didn't know to budget for boxes. Or we had, after the Uber, we moved on to a courier service, and we had two brothers who ran a courier service come in and say, we courier medications all over. There's no reason we can't courier food. And so we tried that for a while. We ended up hiring our own delivery drivers in this whole evolution of our transportation issues, but people were coming out of the woodwork in the community because they loved the idea of what was happening. It was new, it was exciting. People wanted to be a part of it. And there were some issues in the beginning that we had to work out, specifically around things like protected health information. How do we bring volunteers on board, because they will know that they're delivering to someone's house that has a specific condition. And so we had to figure out training for volunteers. What does it look like to make sure they understand protected health information and confidentiality? What does it look like to make sure they understand trauma-informed interactions and they aren't, causing trauma when they go to people's houses to make these deliveries? So we had to work on what that looked like to engage with all the different members of the community that came forward wanting to add their services. We had farmers and food hubs who wanted to start donating to the program. It was really amazing to me how in an urban area like St. Louis to see so many people come forward wanting to be a part of it. I also just started making cold calls to people when I discovered I needed something. I shared with a couple of you that spices were something that people needed, and they're expensive, and they told us they couldn't afford them. And so, we were able to get a grocery store to provide them for us locally. We have Schnucks is based in St. Louis. And we also then were able to find them very cheap online at Amazon. But we had one of our sites that contacted Penzi Spices, if you're familiar with them, and they are providing a year's worth of supplies to their programs. Through the Participant Advisory Council, we started designing the program around their needs. One of the things we created that I wanted to share with you guys is, number one, we started doing a kitchen tool assessment with every family. It not only looked at what they had in their home. Do you have a non-stick skillet? Do you have a baking pan? Do you have measuring cups and spoons and spatulas? Do you have those things so that if I send, do you have a chef's knife and a cutting board? Because if I send these things home to you, I want you to be able to prepare them. So they would fill that out. One of the first things they do with the dietitian. We also asked them if they had a functioning refrigerator, a functioning range top, and a stove. I cannot tell you how often the answer was no to one of those. And so we had workarounds. Number one, we'd flag that for the licensed clinical social worker and say, hey, so-and-so is renting and their stove has not worked for 6 months, or they have a pest control issue in their house and it is not being addressed by their landlord. We had a great connection to Legal Services of Eastern Missouri, the tenants union. And while our social worker helped them figure out a long-term solution, we would send a microwave home. We would send a mini fridge home with them. We had kind of like small to mid-size appliances that we could loan to people while we worked on long-term solutions. And then we gave them these kits based on what their needs were. So that they would be able to prepare the food. Our chef made a list of everything they would need to prepare those menus. We also started sending home a samples kit, a Pantry Staples Kit. So I know if you think of a lot of food, of meal kits, you'll get little packets of spices and things. And we didn't want to go through that, and we didn't know how to put a teaspoon of paprika in a packet. And we also didn't like the idea of sending that much pollution out into the world. So we started giving a welcome kit to them. And that welcome kit had all your pantry staples that we heard from them they might not have around the house. Non-stick cooking spray, a neutral oil, a healthy oil. We had an array of spices they got: onion powder, garlic powder, paprika, cinnamon, cocoa, salt and pepper. We had specific spices that we tried to stick to. And they received all of this, and they were told, if you ever start running out of anything, just contact your dietitian and we will send it out with the next meal kit. Those were innovations that came from our Participant Advisory Council when we heard things like, I can't afford olive oil to roast my vegetables. That would be lovely. I'd love to do that. Or I can't afford spices. My budget doesn't allow for it. So those were a few things that we designed based on their feedback. They told us they wanted snacks. A lot of them have children of school age. And we had one mother who said before the program, she couldn't afford, there were nights that the kids went to bed without eating dinner. And her coping strategy was she always had them at school as soon as the doors opened so that they could get school breakfast. And that she put them to bed early on those nights because she thought it was better that they sleep through the hunger. And that has stuck with me, the thought of a mom trying to figure out how to cope with the fact that she doesn't have food to feed her children. But one of the things moms started asking for, they said, what does a healthy after school snack look like when they come home? And so we designed, it was a fruit, a grain, and some sort of protein. So cheese and crackers with apple slices. And we started giving that as an option that they could select to add to their, and it helped them start with their shopping. They said, oh, I always pick up those little squeezy yogurt packs now when I go to the grocery store. Or I now buy apples and my kids will love to eat them in the afternoon after school. So we helped them kind of build up a menu of easy, balanced after school snacks that they could utilize. The last thing I wanted to talk to you guys about is where we're all going. You guys are at the beginning of your implementation journey, which is really exciting. I think one of the most exciting pieces of this project, and I love the way Sunflower Foundation has put so much thought into this, is that you have an evaluation team to help you look at how to collect appropriate metrics to measure your success with these programs. Because the truth of the matter is, right now, the majority of these programs in the US are funded through grant funding. So you have foundations like Sunflower, that Anthem Foundation, we had Bear Fund support us, that are funding these costs. And I think of that as funding startup costs. But ultimately, we all need to move towards creating a plan for sustainability. And the plan for sustainability is through policy change. Next slide. So I want to talk about two things that we spent a lot of time on. The first is data sharing. So everyone loves their data, particularly in healthcare, and it's very proprietary. I have spent a good portion of the last 5 years working with United Healthcare, Anthem, and Centene on what it looks like to share not only outcome data, but claims data with our evaluation team at WashU. I mean, the amount of legal work that goes in, I would be better off offering up my first child. I don't think they want my first child, but anyway, there's a lot of hoops to jump through when you're asking about data sharing, right? Because everyone needs to keep themselves protected. Some of them see their information as proprietary, but in the end, we were able to get all 3 MCOs to come to the table and for the greater good, agree to give our third-party evaluation system the claims data for everyone who went through the program. It literally took us all 5 years to get to that point, but it is so necessary. I have a spreadsheet that I can show you guys that the evaluation team put together, and it was like, here are all the metrics. Here's where we're at with getting them from each of the MCOs. Here is what Operation Food Search is going to be providing in terms of metrics. It is a crazy list, and we had to go through and make sure who was going to be responsible for collecting and sharing each one. I feel like that was such an accomplishment when we got the final MCO to come on. And the return on investment analysis is going to be key to us changing long-term state and federal policy, because healthcare is driven by profits in the United States. And we need to show that if we're asking people to engage long-term in funding something, that it is evidence-based. And so I know we were doing a study and collecting that data to help form that evidence base for programs targeting women during the perinatal period. You guys are going to be contributing to that evidence base for programs for people with diabetes. There are people across the country that are working to put this data together to make the case, whether you're making it to your state Medicaid department so that it becomes part of your MCO contract to engage in food as medicine, whether you are helping with national efforts to get CMS to say that Medicaid or Medicare is going to start reimbursing for these. The data is central to that happening. Next slide. Oh, one more thing on that slide. It's not all about A1Cs and cost savings. And I think sometimes I forget that because I'm so driven by policy change. The stories that come out of this, the stories of resilience, of change, are just as important. One of the outcomes that I wasn't necessarily expecting is that we use the Edinburgh postnatal depression screening with our moms at different periods throughout. A lot of the moms who were experiencing high food insecurity when they entered the program also had high rates of depression, stress, and anxiety. They were popping really high on that. We found once we got them into the program and we were seeing lower rates of food insecurity, we were also seeing lower rates of depression, stress, and anxiety. Not having enough food to feed your family has a huge impact on how you feel as a person and as a parent. That was a huge weight that was lifted. And there are healthcare costs associated with depression and anxiety. But we also just did some variables looking at how people felt about themselves. And, you know, when you're a parent and you have trouble putting food on the table, you don't feel very good about yourself as a parent. That's a very personal thing, to have to admit that you have a coping strategy for when there's no food in the household. And we started seeing things through the Participant Advisory Council, through teaching basic cooking skills. It started to build people's confidence. Number one that I took away from this is our system is really fragmented. And I think particularly in Missouri and Kansas, pregnant women are only important to us when they're pregnant. So what we heard from a lot of mothers, we did a focus group and one of them said, I feel so discarded. I didn't know I would lose my health insurance after I gave birth. She said, it seems the only time Missouri cares about me is if I'm pregnant. And a lot of services are around that period. We fund services for a very specific period, and then we all withdraw our services from those families, and they're left on their own. And so we figured out a way to keep the program going if they wanted to continue the meal kit portion. Again, it's voluntary at this point, it's donations, but having someplace they could still call after 60 days postpartum or after 6 months was revolutionary for some of them. Our families did not score highly in terms of social support in their life. Low income families a lot of them didn't have relatives that they could call if they were in straits and needed someone to help them pay the rent, or if their car broke down, you know, maybe their neighbor didn't have a car that worked either. They didn't have coping mechanisms that a lot of us take for granted. And so having a program that helped them feel like they could stay connected and not be discarded was really important to them. And I just hadn't thought about the impact. I don't know how you measure that in return on investment. The feeling of connectedness to your community and to feel like you are still valued as a person. But that was something that hit me in the heartstrings. All right, last slide. I am here to convince you in my last few minutes that we are all policy people. How many of you find policy to sound either boring or intimidating? How many of you like to go to your state capitol and talk with your elected officials? Oh my gosh, we have some hands in this audience. That is great. I will tell you, when I started 10 years ago as a registered lobbyist, number one, I was a hot mess. I thought these people were all experts in everything. And so I thought I really had to have myself together when I went in there, and that they were going to ask me hard-hitting questions in every office. That is not the case. I think that along with having participant advisory councils, and this goes back to the question that was asked earlier from the person joining us online, you are all the best advocates, you and the participants that you are serving. And I think that more investment needs to be made in helping people feel comfortable, trained, and ready to go in and have those discussions. And we need to do it in a collective way that we're all providing the same message. And yes, that costs money to do. I'll also hear people say, oh, we're a nonprofit, we cannot do any sort of advocacy. And that's simply not true. You are experts in your community. You know what you see every day. You know what people need. You need to be speaking up. And that is not an easy thing. I heard a lot from you this morning that you're already stretched really thin. in terms of staffing, and that you all have a lot on your plates. This is one of those interventions that I don't want to see it stop in a couple of years when all of the funders move on to funding the next thing. And I don't say that in any way to, funders want to see things become sustainable. They aren't going to fund anything forever. We're lucky if we get 5 years or 10 years of funding to help get something up and running, but it's our responsibility then to make this sustainable through permanent policy change. And we can do it. It can be really impactful for both a participant and for their state legislator to go have a conversation about what this has meant to them in their life. I found data doesn't always work to change people's opinions, but a lot of times meeting someone, a real person, and hearing their story can be really impactful. And so my hope for everyone in this room is that that becomes a part of this process for you as well. That the data and the stories, you become advocates for food as medicine, so that we can get together here in a couple of years, and it can be that Kansas, Medicaid now considers this as part of their MCO contracts, that we move it out of this value-based area where it's kind of like MCOs have a choice of whether or not they fund it and how long they fund it, but it becomes a permanent part of our healthcare structure. And that's not going to happen unless we all get engaged in those discussions. And they can be fun discussions to have. You guys are the experts on this. And once I realized I was the expert going in to talk to them, and there were a few extra scandals in the Capitol, and it's like, oh, these are flawed human beings too. I felt a lot more comfortable in having those really honest conversations about what was needed. The last point I'll say on policy is I think there's also an opportunity for those of us here in these Midwestern states. We are in agricultural states. I can't tell you how many times I've been in the Missouri legislature testifying against a bill to cut SNAP benefits for a specific population, whoever it is at that time. And there's very much in Missouri, and I assume it's here in Kansas as well, you'll have to correct me if I'm wrong, a bootstraps mentality, right? Most of our legislators believe everyone has an equal chance in this world, and that they're against handouts, right? Only very specific populations deserve the help of government. And we like to whittle away at what that looks like because they grew up poor and they made it, so anyone else can do it too. And I shared this with someone last night, but I grew up in a union home, a working class home. But I had two parents at home. My dad worked 60 hours a week. Those jobs don't even hardly exist anymore. My mom cooked dinner for us every night, and they paid for me to go to public school, to University of Illinois, because that's what they could afford, and they knew that was important to my future. I am still coming from a place of privilege and having had that experience. My sister and I were just talking the other day that most people, like, we grew up ideal, the 80s were idyllic. Like, our mom was home. We ran around the neighborhood all summer. Like, that doesn't exist because that doesn't work in families anymore. And so I can't remember where I was going with this point, but there's a lot of privilege in the Capitol that I think we need to start dispelling. I also think on an agricultural note, that's a way to connect. So if they can't connect with the idea of giving, that we need to provide assistance to people to improve their health so they can become more productive citizens of whatever state you are in, that we can fall back on the fact that there is a lot of work that could be done in supporting your local farmers with food as medicine programs. So I think that is another way that we can open those conversations that gets away from the, does someone deserve a benefit, to talking about how this can benefit the entire community by tying it into agriculture. I will leave you with one last quote and my contact information. If any of you want to become policy people, call me. It's my jam. On the way here, I was listening to Brene Brown's The Gifts of Imperfection, because I'm always all about using my trips across the state to do a little personal development. Courage has a ripple effect. Every time we choose courage, we make everyone around us a little bit better and the world a little braver. And our world could stand to be a little kinder and braver. I bookmarked that when I was driving yesterday because I think this work takes courage. And I think we're going to have to be brave if we want to secure a future for this work. So with that being said, I'm here to be your biggest champion in this work and turn you into policy buffs like I am. Thank you.